All right, thank you for having and hosting me today to talk on this topic. I'm going to talk about scaphoid fractures, fixation, when, why, and how we fix these types of fractures. So I have nothing to disclose. The scaphoid is one of 8 small bones in the wrist. It's the one highlighted there in yellow. And the unique thing about the scaphoid is that the wrist is comprised of 2 rows of bones. There's a distal row and a proximal row, and the scaphoid is unique in that it crosses into both rows, so it links them. It acts as a link between the 2 rows of bones. And unfortunately for the scaphoid, this does make it more susceptible to injury. Since it links these 2 bones, when the proximal row is maximally flexed and the distal row is maximally flexed and they kind of reach their limit, the scaphoid is often the bone that will fail and fracture in this situation. They're a very common fracture because of this. They represent about 80% of all the fractures of these 8 small bones in the wrist. They also have a high risk of not healing appropriately, or the bone having a loss of blood supply and portions of the bone dying because for several reasons I will discuss in a little bit here. And then because of those factors, patients can go on to have significant functional and painful problems if they suffer a scaphoid fracture that does not heal appropriately. So the blood supply to the scaphoid is somewhat unique because it kind of crosses both of those rows of carpal bones and articulates with multiple bones. A significant portion of the scaphoid is covered by cartilage. 80% of it is covered by cartilage, which leaves little bony surface that's not covered by cartilage for blood supply, for blood vessels to enter. So the primary blood supply to the scaphoid enters from the distal aspect, closer to the fingertips, and then actually works its way back inside the bone towards the proximal aspect. And because of this unique blood supply that's inside the bone, we call that a retrograde blood supply, where it's coming from distal and heading proximally inside the bone. If there's a break in the bone, it can disrupt the blood supply, particularly to that proximal portion of the bone, which can have a number of implications for healing and for the potential development of death of a portion of the bone. So when someone fractures their scaphoid, if it's not treated appropriately or does not heal appropriately, there can be a number of sequelae or problems that can result from that, which I alluded to a little bit earlier. So if the bone doesn't heal, that in and of itself can be painful. The raw, unhealed edges of the bone rubbing and moving can cause pain in and of itself. If the bone does heal but heals in a poor position, typically that position is a flexed position, which you can see in that second row of pictures down. That can also have implications for how the wrist is able to move, and it can cause limitations in the movement of the wrist, or can cause pain when prominent portions of the bone impinge with motion. So that can lead to stiffness, pain. And then the last thing that I'll just briefly mention is that if the bone does not heal appropriately, it alters how the other bones in the wrist will move, because we discussed, it's a very important link between the 2 rows of bones in the wrist, and patients will go on to a predictable pattern of arthritis in their wrist over the course of several years, 5 to 10 years, developing worse and worse arthritis at different segments of the wrist if they have a scaphoid fracture that did not heal, and that's due to the abnormal motion that results from that break. So we're trying to prevent all these things by trying to get these to heal appropriately the first time, or when it presents to us, get it to heal after the fact if it didn't heal appropriately the first time. So when we see scaphoid fractures, or we have concern for scaphoid fractures in the office, there's a number of things we look for in these patients. Careful physical exam is very important, as well as obtaining a history with the mechanism of the injury, how it happened, where their symptoms are, where it hurts. So the classic area where people have pain is on the thumb side of the wrist. There's an area called the anatomic snuff box, which is between several tendons on the thumb side of the wrist where often patients with a scaphoid fracture will be point tender in that spot. And then loading the thumb can cause some pain, movement of the wrist. But that anatomic snuff box tenderness is the classic and most reliable method of evaluating someone for a scaphoid fracture if there is concern for that on physical exam. So then we typically will also have an x-ray of the wrist, and it's nice if we can see the fracture on the x-ray. That makes the diagnosis much more simple. But unfortunately, because the abnormal geometry and position of this bone in the wrist, it can sometimes be difficult to see the fracture on an x-ray. So it's not uncommon that if we have high clinical suspicion for scaphoid fracture, we'll obtain additional imaging, and that may be in the form of an MRI, which can be very sensitive for evaluating a bone bruise or a subtle fracture line in the scaphoid. Sometimes we'll get a CAT scan, which can also identify more subtle fractures. A CAT scan can also be useful to evaluate if there's any displacement of the scaphoid, because you can evaluate the bone in very high detail in 3 dimensions. So even if you know there's a break, but you want to see if it's out of place at all, a CAT scan can be an option that we will sometimes obtain. And then the CAT scan can also show evidence later if there has been healing of the break. So if you're following a patient to evaluate if the break that you're following has healed appropriately, what percentage of it is healed, the CAT scan can be a good test for that, and it can show if there's any signs of death of portions of the bone. So when we first see patients, if there's clinical suspicion for a possible scaphoid fracture, but the x-rays are inconclusive or appear negative, we will often start with the patient in a brace or a splint or a cast while we await either additional imaging or an x-ray at a later visit, just because if there is a break, we don't want it to go untreated for any prolonged period of time. So immediately we'll get them immobilized and then move on to any next steps from there that we might need to consider. If there's a displaced fracture of the scaphoid, the treatment option is pretty straightforward. As we discussed, if the bone heals in a poor position, it can have significant consequences for patients down the road. So in those situations, we will have to do a surgery. It can often be a small surgery, especially if it's addressed acutely in the acute setting, to realign the bone and fix it. And typically that fixation is with a small screw that's completely inside the bone, so it's not an implant that patients will feel and typically does not need to be removed at a later date. But that provides stability and appropriate alignment of the bone to improve the potential for it to heal and heal in the appropriate position. The slightly more complex and controversial treatment discussion is when you have a scaphoid fracture that's not at all out of place. So you have a couple options. They do need treatment. You can't let them just go on their way. So the treatment options are either immobilizing them with a brace or a cast, or fixing it. So the similar type of fixation with that screw is often what we will do if that's the route the patient and the surgeon choose to go. But there is definitely some debate on what to do in these patients when there is a fracture that's not out of place, that's been identified, whether to treat them with immobilization or in some situations go right to doing surgery. There are some benefits to doing the surgery immediately that we'll discuss in a little bit, and some considerations on when we might do that versus treating a cast. Another thing to consider is the location of the fracture. So because of that blood supply, which we talked about earlier, where the proximal portion of the bone has a little bit more tenuous blood supply, especially in the situation where there is a break in the bone, when there's a more proximal fracture closer to the wrist, farther from the tips of the fingers, that may push us more in the direction of fixing it to have a more reliable environment for healing of the break. So there's been a number of studies that have looked at this problem. The type of fixation is that screw that we talked about, but it can be done through a very small focal incision, basically just big enough to fit the screw. through the skin and into the bone. So it's a minimally invasive surgery, but it is a surgery nonetheless, so there are a number of considerations that need to be considered when deciding whether or not to do that. A number of studies, including this one, have showed that there is faster healing rate and and a lower risk of the bone not healing if you do fix it with a screw. So those are definitely important considerations. In this study in particular, the rate of healing and the risk of non-union were lowered by about 50% the rate of healing and the return to work were cut in half with screw fixation. And then there was also a slightly higher rate of, or lower risk of the bone not healing. So in the patients that were treated with a cast, they had a union that was identified an average of 12 weeks versus 7, so almost cut in half in terms of how fast it took for the bone to heal. And then return to work was 8 weeks versus 15, so also nearly cut in half. So that could be an important consideration for someone who's trying to either A, get back to work, or B, get back to a sport, or get back to certain activities that they're trying to do, whether that's take care of young kids, etc., where they need to be potentially or ideally out of a cast or immobilization sooner. That can be an important consideration to have. Or in a situation where you don't want to run the risk of it not healing the first time. So if you have the ability to provide the patient with a lower risk of it not healing with the first line of treatment by putting in a screw, that might be an important consideration for you and the patient. This is just another study that looked at a similar situation. This is a diagram of what it can look like when we put the screw in. So again, a very small incision, basically just big enough to fit the screw in and fit the screwdriver to screw it into the bone. This study had many studies, including this one, have had very high healing rates when acute fractures that are not displaced are fixed with a screw at or near 100% rate of the bone healing. Whereas cast treatment or immobilization of these fractures is often closer to 90%. So even though it's 90% is a pretty high number, those 10% that don't heal, it can be a significant problem. So trying to minimize that can be something that we don't take lightly. And then the other factor to consider is where the break is in the bone. So in this study in particular, it looked at comparing more proximal fractures to ones that are at the waist or in the distal aspect of the scaphoid. And it did show higher risk of the bone not healing, 2 to 3 times higher risk of the bone not healing when the fracture is more proximal. So definitely something important to consider. And if there's a way to reduce that risk for certain patients, that might be something important to consider for their goals. The other thing I want to touch on briefly is what we do when we encounter a situation where the bone hasn't healed. So now some time has passed, and the patient has a break that has not healed. In situations where there's still just a very faint fracture line that's not out of place, without death of any portions of the bone, fixing the break with a screw through a percutaneous fixation method can be a very effective way of treating that break. This study was 100% union rate. But there are situations where the bone has either not healed and become out of place, or not healed and has had resorption of portions of the bone. So we need to consider other options when that situation has happened. So if the bone is not healed and it's in a poor position, that would typically necessitate a larger surgical approach to line the bones back up, and also oftentimes remove any of the scar tissue that's formed at the site where the break was. So this is just a diagram of what the surgery might look like, where we put wires into the bone to manipulate the two ends of where the break was. It allows us access to that portion of the bone that's broken to debride the scar tissue, the fibrous tissue. And then oftentimes, if this situation has happened, we'll want to take some bone from somewhere else and put it into that fracture site to provide fresh, new, healthy bone cells, biology to stimulate healing at that site. And we have a number of options for where we can get that bone from. It's typically from the patient's own bone, because we want their own bone cells there to promote healing. So we can take it from local sites through the same incision that we're operating on, from the end of the forearm. You can take a small section of bone from the hip or from the knee. And then there's also options to take a piece of bone with a blood vessel as well, reattach the blood vessel. So you're actually putting in a piece of bone that has its own blood supply to that site. And that could be something that we consider, especially for certain fractures that we might worry have more challenging healing potential. So in these X-rays, in this situation, you can see that on the X-ray on the right, there's a subtle area that's like a little lighter right here, and that's where some bone was taken from, put in the fracture site, and then a screw was placed across it to compress all that and strongly hold it in place. In this next example, the patient already had a screw in place, but despite that didn't heal. So in this situation, you have to take the old hardware out, again, clean out any of the scar tissue that formed where the fracture site was. That middle picture is an instrument called a curette. It's like a very small, sharp spoon that we can use to debride that fracture site. And then again, put healthy bone cells in from another location, transplant them there, and put a screw across that site to try to get it to heal. There are other constructs that we can consider too in certain more complex situations for fixing and stabilizing the fracture. You can put 2 smaller screws in instead of 1 bigger screw. There's a newer implant that's conformed to the front of the bone, a small plate with screws in that can fix across a fracture site, and that can be useful in certain fracture patterns or locations, or to hold the bone graft in place, act as a buttress. So things that we discussed: scaphoid is a very important bone in the wrist, very commonly fractured, does have trouble healing or can have trouble with its blood supply when it is fractured. It's important to identify when it's fractured, so we often will consider obtaining advanced imaging in the form of an MRI or CT scan. It's important to identify if it's fractured because there are serious sequelae or downstream consequences of the bone not healing appropriately. In some situations, we will consider casting versus fixing these fractures, and important considerations to discuss with patients when choosing which treatment to pursue is the time to it healing and the reliability of it healing important to you to undergo the additional risks of having a surgery. And then we discussed the location of the fracture and how that might play into that decision of whether to cast or fix the bone. And we also discussed, if the bone didn't heal, what we might do in those situations down the road. Thank you.